kid.
Apologies, I just pushed the record. Forgot.
Great. Okay, that's where we my family went in the summertime. That's where you heard Under the Boardwalk. I don't know if you know that song. That's where the boardwalk was built. We spent our summers there, and this was a hotel there. And it was built in 1881. In 1975, it had been dilapidated, and there was a big fundraising drive, and it's still there. It's down 2 towns down in Margate, New Jersey, and it's now a museum. It's the Museum of South Jersey. If you can take a tour in here. If the eyes are looking at the Atlantic Ocean, the back end is looking at the city of Margate. You can go up here. It's called a Howgoo. It's kind of quite a tourist attraction. So that's the elephant in the room. And what the issue was, which we knew it right away, but the powers that be, didn't want to acknowledge it, was that hormones that are synthetic our bodies don't like, and it rejects it. And if you think about, give it about 30 seconds to a minute thought, you'll realize, what exactly happened. Synthetic hormones our body looks at it as foreign. It's no different than if any of your any of your audience has any type of autoimmune disease. When there's invaders that come in that the body detects as foreign, it will build antibodies to them, and it will build cells around the organs to try and protect it. So when the most prescribed drug in the United States from 1965 to 2002 was Premarin, synthetic estrogen made from horse urine. And I'll show you the chemical composition in a minute. And our bodies didn't like it. Now, I was, like Lisa said, I was a failed OBGYN and in 1978 to 1980. And we would do, what OBGYNs did. We would do hysterectomies for whatever reason. And then we would give our patients a Premarin, the synthetic estrogen. And we would tell them they didn't need progesterone, the balancing, because they didn't have a uterus anymore, so they didn't need it. And I remember saying when I was a first-year resident to one of the senior residents, because we would have a clinic on Tuesdays and Thursdays, and we would see the patients, back or for checkups and whatnot. Let me tell you, 30 pap smears in 2 hours on Tuesdays and Thursdays was a lot. 30 pap smears in 2 hours is a lot. My friends thought I was 25 years old. My friends thought I had the greatest job going, and I said, it's work. It's it's not. So think about it. We're putting horse urine into your system, and specifically estrogen. So where does estrogen affect mostly? The breast, the uterus, and the ovaries. So what is our body going to do? Our body's going to protect the breast, the uterus, and the ovaries. And how does it do it? It forms cells around them. What are excess cells? Cancer, right? That's what excess cells are. Cancer is excess, abnormal growth of cells. And so it would take, it didn't take a genius really to figure it out, but we didn't recognize it back then. And then in 2002, when that World Women's Health Initiative came out, and there was that big hullabaloo around it. I remember saying when I first heard it, I said, I knew this 20 years ago. What's the big deal here? So by that time, we were using the natural, the natural compounds. And of course, the powers that be decided that it didn't matter if it was natural or synthetic, it was all the same. And there was a huge drop off, and they really did, particularly women, a disservice by handling it the way they did. And you'll see as we go through some of these so-called complications of all of the hormones, that this kind of knee-jerk reaction is pretty much typical, all throughout our sort of the history of this. So synthetic hormones, we give you something that has some estrogen in it, but 70% of it is made from horse material. Our body isn't going to like it. Estrogen in combination with synthetic progesterone had a 69% increased risk of developing breast cancer than women who didn't take any type of hormones at all. Premarin alone given to older is 6 to 10 years post-menopause beginning. So it could be anywhere from 55 to 65 on average. Postmenopausal patients cause a statistically significant increase in heart attacks and strokes. And synthetic progesterone increased breast cancers, heart attacks, and dementia. And you'll still hear it today. You can go on. There's a like a medical YouTube called View Medi, and there's all sorts of gynecologists and endocrinologists from the big medical centers like Yale and Harvard that'll tell you that it doesn't matter the type of hormone it is. But of course, one we know that, and two, the big pharmaceutical companies are now making bioidentical hormones. So we've proven right all along. But we're always made fun of and whatnot. So this is just a schematic of, this is a natural hormone here, estrone. Now this is the bad guy. We don't want this one anyway, but this is estrone. This is the bad guy. These are actually birth control pills. These are estrogens that are in birth control pills. So these are equine estrogen products. And you don't have to be a biochemist to see that they're not the same. That's the point here. They're just not the same. The synthetics have at least 10 estrogens. Only 3 of them are human. Premarin caused increases in blood clots, strokes, and heart attacks. Oral estrogens cause an increased in blood clots also. And also oral estradiol. Estradiol is your one of your natural estrogens, your bioidentical estrogens. And a lot of pharmaceutical companies here, I don't know about in where you are, they'll make patches, they'll make pills. We still see an increased incidence in blood clots with oral estrogens, even the estradiol, the natural one. So we try to stay away from them as best we can. Provera, we already mentioned, is the synthetic progesterone. It increases breast cancer and vascular inflammation at least 3-fold, and natural progesterone does not. This was a study done, and it shows per breast cancer per 100,000 women years. This is that WHI study, 521. This is synthetic estrogen and synthetic progesterone. This is no hormones at all. This is natural estrogen, natural progesterone, and natural testosterone. And over here, less than if we gave you no hormones at all is just testosterone only. And what we find is that we can cover probably about 90% of the symptomatology that estrogens, even natural estrogens, cover with an adequate amount of testosterone. We'll go into that in a little bit. Mortality, decreased in mortality with therapeutic estrogen, 28% less. This is less. I should actually have this going the other way. I made this graph backwards. This is 28% less deaths in females with natural estrogen versus synthetic estrogens, and all-cause mortality 23% decrease than those who had nothing at all. Estradiol protects against heart disease, dementia, and osteoporosis. These are the 3 biggest killers of women, at least in the US. It improves insulin sensitivity, restores sleep, improves hot flashes, night sweats. It maintains pelvic health and with lubrication, and it protects against colon cancer and macular degeneration. And unlike conjugated equine estrogen, the Premarin, it's really safe for preventing long-term degenerative diseases, osteoporosis, heart disease, diabetes, and even cognitive impairment. Transdermal, so that's your creams and your patches, does not increase the incidence of blood clots, strokes, and it improves quality of life and blood pressure. This one's really interesting, and this was actually before that WHI study, and I've just looked up a new one. I found one in 2021. This one's in 1999, believe it or not, but in 2021, and the numbers are the same. This is mortality post breast cancer. So all of these patients had breast cancer 11 and a half years after after breast cancer. 1/3 of the patients who had no hormones were deceased. Those patients that had natural estrogen and natural progesterone and natural testosterone, only 6% of them were deceased, 94% survival rate. If they had testosterone and progesterone only and an estrogen blocker, 7/8 of them, 13% of mortality. So you can see here, we have it actually all the way backwards because, breast cancer, you can't have hormones. And you can see here, that this was 1999, and I didn't get a chance to put in it, but I found a new one in 2021, and the numbers are exactly the same. So we have it exactly upside down. We should be giving you hormones if you have breast cancer, not depriving you of them. This is progesterone versus medroxyprogesterone, which I got my catalog from my medical supplier, and they're having a sale on medroxyprogesterone for Thanksgiving here at $5 a bottle. We can stock up on it. The natural progesterone is a little bit more expensive, but again, the point here is that these are synthetics. This is a hormone. These are drugs. Okay, and they'll call it. You might hear them called progestins. So a progestin is not distinguished between natural and synthetic progesterone. Natural progesterone maintains pregnancy, improves mood, sleep. It acts as a diuretic. I think we talked to you about that, Lisa, for somebody that has hydrocephalus. We talked about.
We're working on that for mom. Yep.
And we use this for traumatic brain injuries, acute traumatic brain injuries. If we get progesterone on board, 8 milligrams per kilogram IV within 24 hours, there's at the end of 1 month post-traumatic brain injury, we have a 50% decrease in mortality than those who did not get it. It reduces estrogen progesterone is your counterbalance to estrogen. It reduces estrogen stimulation. It prevents breast cancer, and there's no evidence of increased cardiovascular disease, and improves blood lipids. And the synthetic progesterones, basically everything over on the right-hand side, does the opposite. So you need to really stay away from the synthetics. 80,000 women 80,000 postmenopausal women, 69% increased risk of developing breast cancer from those who didn't take it at all with the synthetics. And with the naturals, there was a 40% decrease with natural estrogen and natural progesterone versus progestin use alone. And this is natural. This is synthetic estrogen. So this is Premarin, a 20% increase. This line here means no patient had no hormones at all. This is a 20% increase in synthetic estrogen. This is a 40% increase. This is synthetic estrogen and synthetic progesterone. There was a pill called Prempro that we used to use. This is natural estrogen, natural progesterone, 10% decrease than if we gave you nothing at all, and 50% decrease from the synthetics. And this was done in 2007 with 55,000 women. A women's health initiative that caused all the hullabaloo had a third less patients. So let's talk about the hormone specifically. Like I said, this is my own sort of breakdown. I don't think you're going to find this in any book, but unless the ones I wrote. But it sort of gives me an idea of which ones where I need to focus, and maybe focus a little bit less. So this slide is very busy, but if you're going to prescribe hormones, if you want to know about hormones, you really need to know what it is. This is called the steroidogenic pathway, and this is how hormones are generated from scratch. And all of this activity takes place in the liver. And the most important thing to know is that all of the hormones, so here's testosterone, here are your estrogens, here's cortisol. If we had a 3D, thyroid would be sort of coming back at you at the screen. And DHEA is a precursor, and as is pregnenolone. But all of it comes from, the stuff we demonized, as genius doctors told everybody not to eat fat in the 80s and 90s. And so what do you think? And remember, 60% of our brain is cholesterol, right? What do you think happened when we started giving you drugs to get the cholesterols down to zero? Yeah, which is basically what the cardiologists do. And to just take a guess, right? So anybody who's on one of these drugs, these statin drugs, pull out the package insert and look at the list of side effects. And if you know what to look for, what you'll recognize is that the list of side effects are basically all of the side effects or what happens when you have low hormone levels. So they'll have hot flashes, night sweats, brain fog. They won't tell you it's from low estrogen because we block the cholesterol, so you can't make the estrogen anymore. but they'll sort of just list the symptoms. And if you look at it, I mean, it's 3 pages long. So the statins actually work. There's a higher up pathway here, and they work up here. So it blocks all of this out. So we'll talk about the 7 major hormones. We'll talk about testosterone. So it's kind of the granddaddy of all. And the first thing you need to know is that this is truly an anti-aging substance. This is more than, at least in the US here, all you hear about is sex. It really is universal, and sex is really, I mean, it's a part of it, but it's really, you could skip over that part of it. And if you have a life without testosterone, you're really not feeling very well. It's an antidepressant. It's an anti-anxiety agent. It's useful for strength, energy, sense of well-being, mental clarity. It controls neuronal excitability. So it's a calming agent. It protects mitochondrial dysfunction. That's a big term. You've got people talking about that, Lisa? Mitochondrial dysfunction.
Yeah, everybody. Yep. The vices of everything.
It increases interleukin 10, which is a pro-inflammatory cytokine. Low testosterone, anxiety, depression, fatigue, suicide ideation. Patients that have had traumatic brain injuries, the first hormone that sort of dissipates is growth hormone, and the second is testosterone. All of these patients that have suicide ideation and even complete suicide have low testosterone levels, for their sort of age group. On the other hand, just as an aside, autistic children, especially boys, have very high testosterone levels for their age. They also have very high growth hormone levels, but low IGF-1, which is the usable portion. So they have this sort of empty-headed syndrome. So they have big heads, but there's nothing in them. And that's where a lot of the behavioral issues come from. So loss of muscle mass, loss of energy, loss of balance, mental fatigue, and of course, loss of libido. So there's all sorts of controversies. I mean, things do happen with testosterone. You will get an increase in red blood cell count. For men, you'll get an increase in prostate tissue. It was thought that for the longest time that testosterone caused prostate cancer. This came from a paper that was written by 2 urologists in 1941, and it's still taught today. It was done on 3 patients that had prostate cancer. They gave them testosterone. 1 got better, 1 got worse, and 1 stayed the same. So the conclusion was that 67%, 2/3 of the patients who get testosterone with prostate cancer get worse, and then they'll die. I mean, that's where it came from. And I have students with me. I mean, they're still taught that today. It was not looked at for 50 years. It was pretty much debunked in the 90s. And there's a new study just came out in the less than 6 months ago. We'll look at that at some point. We're still sort of digesting that. And again, it was a big hullabaloo about the study. And what did they use? They used synthetic testosterone. Again, they weren't using the natural ones. So these are all the things that have sort of been associated with testosterone. And pretty much, you may get a little bit of prostatic hypertrophy. You will get increased red blood cell count, but it was thought that they conflicted that with polycythemia vera, which is a blood tumor, which is a genetic blood tumor. So you'll get an increase in red blood cell count. That's one of the reasons you get more energy, but you don't get an increase in white cells or in platelets. So you only need a blood count to take a look at that. So we had a lot of VA patients, the Veterans Administration patients here, and they'd go back, they'd get their blood done there, and they would see that the red blood count was high, and they'd get all excited about it. And their doctors there made them all go get bone marrows because they said they had this polycythemia vera. And I kept saying, I said, that's not what it is, but talk to the wall. I just made this as a sort of just a list here. All of the references are here if you want them. We do a whole lecture on just complications of testosterone, and we go into the literature. But these are the conclusions, and the numbers there at the end. The references are there, Lisa, if you want them, if your audience wants them.
Yeah.
High testosterone levels does not increase the risk of prostate cancer. Testosterone therapy doesn't increase the risk of prostate cancer. It doesn't increase the risk of progression in men. It doesn't cause or exacerbate metastatic prostate cancer. And testosterone therapy in metastatic disease does not cause rapid progression and death. doesn't do anything. This is what to do. This is kind of a little bit technical. If you patients who have prostate cancer, and these are sort of the four remedies. X-ray therapy seems to have the lowest recurrence rate, and this is a way to deal with it. And this is more for your physicians about what to do. Also, erythrocytosis, which is increase in red blood cell count. So the conclusions here: high testosterone does not increase the risk of blood tumors, heart attacks, strokes, or blood clots. So that's testosterone. I don't know if anybody has any questions, or just keep going and we'll handle it at the end.
Keep going. Yeah, we'll do it at the end.
Okay. And so again, so estrogen, we pretty much went through this when we talked a little bit about polycystic ovaries. Estrogen has 400 functions that have been identified. It's probably the most studied molecule in the history of the world. The ones that we need to pay attention to are in blue here. So increased metabolic rate, increased insulin sensitivity. So it improves blood sugars. It increases blood flow to the brain. So early on, when we first started replacing testosterone in guys, we would give them enough testosterone to get their blood levels to 1,500. Normal, depending on what lab you're looking at, could be anywhere from 300 to 1,000, which is a ridiculous number anyway. But and then we'd see their estrogen levels go up, so we would give them estrogen blockers to get it to 0. Well, that was wrong, and that was wrong. Because you get to a point where you're only going to end up with side effects if the testosterone levels are too high, and estrogen drives blood flow to the brain. So these guys were falling over, they were forgetting things, they were putting their keys in the freezer, they were driving their car through the back of their garage into the kitchen. So we quickly realized that was not a way to go. So then we were partially blocking estrogens. Well, it turns out that what happens in men is the same thing that happens in women. With no estrogen or low estrogen, you end up with osteoporosis and heart disease. So now what we do is, if they have symptoms of high estrogen, I'll go through that in a second, then we'll bring it down somewhat. But otherwise, we just leave it alone. It will improve plaque in coronary arteries, and it maintains skin collagen. If you, I don't know if you have like nursing homes in where you are, but
yep.
by this time I should have been thrown in a nursing home. So especially women, if you go to the lunchroom there and you see them sitting there, the ones that are sitting up and they're playing mahjong and they have nice smooth skin, and and they're going out, they're going fishing with their grandchildren. Those are the ones who had hormones. And the ones that are slumped over and they've had osteoporosis, fractures, and they can barely pick their head up, and their skin's all wrinkled and all, those are the ones who did not. And it's pretty stark. So estrogen will reduce heart disease by a 40 to 50% overall risk. It acts as a natural calcium channel blocker, so blood pressure, energy, mood, concentration, bone strength. It will lower bad cholesterol. It aids in the formation of neurotransmitters such as serotonin, and it decreases depression, irritability, and anxiety. And so not enough estrogen, hot flashes, night sweats, brain fog, belly fat, vaginal dryness, poor libido, headaches, wrinkles around the mouth, increased blood sugars, increased blood lipids, and increased heart disease. Too much estrogen, we talked about cysts. So ovarian cysts, uterine cysts, which are fibroids, endometrial cysts, endometriosis, irregular menses, elevated estrone. So estrone, there's 3 types of estrogen. Estrone is the bad guy, and that's the one that will cause accumulation of fat in the belly, weight gain, and in men, prostate enlargement, and then what we call emotional lability and tearfulness. So that's estrogen on the fly. Progesterone, we talked a little bit about progesterone. It balances estrogen. Basically, that's it. It improves sleep. It has a calming effect. It lowers blood pressure. So our patients are perimenopausal patients, early postmenopausal patients. When they come in, they're agitated and they're irritable, and they hate the kids, and they're kicking the dog, and they're screaming at the husband and throwing oven racks at them. And they went to their doctor and they got Prozac and they got Xanax and they got Valium. God didn't make a Valium deficiency, But it takes a little bit of time. It takes a couple of weeks, but about 3 to 4 weeks of adequate progesterone, and all of a sudden, all the symptoms go away. And Lisa, I know, in fact, I've listened to it this morning. I know you've had Carol Peterson on.
Yeah, yep, she's brilliant.
And
yep.
She uses a lot higher doses than I do, so I'm slowly getting there. So progesterone is your savior. Progesterone is our friend, and progesterone is one of the main remedies that we use for that polycystic ovaries that we mentioned earlier. Low progesterone is actually thought to be the cause of breast cancers, not high estrogen. And remember, it's a balance, but low progesterone, 10 times the increased death rate from all cancers with patients with low progesterone. And this is 700 patients followed up for 33 years. I mean, that's a long time. 5.5 times increased incidence of breast cancer in premenopausal patients with low progesterone. Progesterone deficiency, I just mentioned it, agitated, irritable, can't sleep, or libido, headaches, short-tempered, depression, mood swings, and then the symptoms of excess estrogen, which we've already just mentioned a number of times. Usually too much progesterone it isn't usually a problem unless we've been treating someone with progesterone and we've sort of overshot the mark, but you can get some bloating, you can get some depression. Basically you're going to feel drunk or hungover. That's usually a symptom, and sometimes some water retention also. I did a whole lecture on pros and cons, because in the U.S. the standard is if the patient's had a hysterectomy, they don't get progesterone. And so, in fact, I was at a panel discussion, and the endocrinologist said they don't have a uterus, they can't get pregnant, they don't need progesterone. Well, all of these issues here are what happens when we have adequate progesterone. So, increased diuresis, blood pressure, smooth muscle, sleep, memory. Again, in head injuries, it reduces neuronal blood loss. It's an anti-inflammatory. It regulates your brain chemicals. It keeps you calm. It improves thyroid function, and all of it prevents all of these things over on the right. Breast cancers, memory loss, slowed thought processes, stress, anxieties.
Oh, we lost you. Hey, Dr. Bill.
Good stuff. And for OBGYN specialists don't know this, at least not where I live. I may pop out here. It says my internet connection is unstable, and when we're running our things, it sometimes drops out. So I'll come back if I get lost. Okay.
Yep. Cool.
Growth hormone. So here's another. So growth hormone stimulates cell growth and cell reproduction. Growth hormone actually deals with strength, energy, sense of well-being. It's why our baseball players, when they were taking this stuff, get hit 45 home runs when they were, or 75 home runs when they were 45 years old. That's not natural. But what we look for, in our practice mostly, is for what is known as executive function. So the ability to plan things, or if it's low, the inability to plan things, obsessive compulsive tendencies, the ability to start projects, the ability to finish projects easily or not, the ability to multitask. That's growth hormone is adequate growth hormone is key there. And that's what this is here. And this is what there's a big disconnect, especially in autistic kids, where they have a lot of growth hormone. It's high, but the IGF-1, which is the usable portion, and again, we're just giving you an overview here, so I'm not going to get too technical, is actually low. And there's a block in that pathway, and that's the reason that these kids have all sorts of behavioral issues. Thyroid, I got 15 minutes, huh? So what does the thyroid do? So patients come in and they'll say, I've had thyroid disease for 30 years, and I ask them what the thyroid does, and I get all sorts of answers. But in 4 words, the first 2 was, it's your slide's missing. Gas pedal. That's what it is. It's your gas pedal. It's your energy, right? It tells your body how fast or how slow to go. There's 4 types of thyroid molecules: 1, 2, 3, and 4. We only deal with 3 and 4 because we don't know what to do with 1 and 2. The T there stands for tyrosine, which is a protein. It's not thyroid. The numbers stand for the number of iodines attached to the tyrosine. The 3 is the part that does the work. The 4 is the store unit. Thyroid also makes calcitonin, which produces calcium, which is always left out, at least here, because according to the specialist, all we're supposed to use is synthroid, synthetic thyroid, which is just T4. So T4 converts to T3. That's how you get most of your T3, the usable portion, but not all of it. And then one of the side effects of long-term use of synthroid is osteoporosis, because you lose calcium. Well, you lose calcium because we're not replacing it, because the thyroid, it makes calcium and we just forgot about it. This is just a schematic of a thyroid molecule. This here is, it looks like a sort of a stick man here. This is that tyrosine. Any type of thyroid supplement should have this in it. Okay, here are the iodines. Here's the 4, here's the 3. But notice over here, there's another 3, but it's upside down. This is an inverse T3 or an active T3. We call it reverse T3. And 90 to 95% of the time, it's produced from too much cortisol, stress hormone. So I use this, actually, we order this reverse T3. I use this as a proxy for cortisol, and it works quite well. The standard is either draw cortisol levels, and that can sometimes be tricky, or there's a saliva test. I'm sure you're familiar with it. Some of your, where we have you spit in the tube 4 times a day, and it'll give us how much cortisol there is, and there's a graph you get, and then you follow it from a norm. It's $250 in the US. None of the insurances pay for it. This is about $8. It comes with the regular thyroid test. It's 90 to 95% accurate. So we can use over here. Here's the symptoms of thyroid disease. So you need to be Goldilocks, not too much, not too little. For hypothyroidism, it's dry skin, dry hair, fingernails crack and break, constipation, can't lose weight, cold all the time, tired all day long. 98% of the time, the patients that we see have some, if they come in with a thyroid issue, it's low thyroid. That's pretty much why we just pay attention to that. It's just the opposite. So you're speeded up if you have hyperthyroidism. So you have rapid heart rate, bulging eyes, sweating, soft nails, diarrhea, losing weight. So it's pretty much the opposite. By the time they get to somebody like me, the only time they're hyperthyroid is if we gave them too much thyroid supplement. The medical model versus what we look at. So the medical doctors tell us that it's a failure to convert T4 to T3. The only thing you need to look at is TSH, which is thyroid stimulating hormone, which is the hormone that's made in the pituitary. It's the detective. It detects how much is in your system. If you don't have enough, your brain will tell you to make more. If you have too much, your brain will tell you to make less. So that number that we get is an inverse. So I don't remember the units off the top of my head, but 0.4 to 4.5 is sort of the parameters. 4.5 means you're low. 0.4 means you're high. Patients will get their lab values and they'll see it's 0.3. Oh, my TSH is low, so they'll take more thyroid medication. Well, then it goes lower because it's an inverse. We look at all of these things on the right. So we look at diet, and particularly gluten and gliadin. We're looking at oxalates now, also toxins. So in the U.S., it's arsenic, mercury, cadmium, aluminum, and lead. Those are the big 5 there. Infectious disease, the number 1 is Epstein-Barr virus. So kids that had mono in their late teens or early 20s, 10 years later end up with autoimmune thyroid issues. But other things, hepatitis, and hepatitis can be chickenpox. It could be herpes. It could be cold sores, Lyme disease. The one we like to see is H. pylori, because we've actually treated H. pylori and had the autoimmune thyroid disease disappear. That's pretty much the only one we've actually had a quote unquote cure on. And Yersinia, which is food poisoning. HPA axis, so this is your cortisol abnormalities. Iodine deficiency. I can go into a whole hour on iodine, just on iodine. Doctors, at least in the U.S., are what we call iodine phobic. Iodine's going to kill you because they, again, another genius thing that happened in the late 40s and early 50s. They decided that iodine was a toxic poison. These scientists used radioactive iodine and injected rats with it, and of course the thyroids died, and so they decided that food grade iodine did the same. At the same time, there was a big push for fluoride in the water supply here in the U.S. Fluoride and iodine, or if you remember your chemical table, are chemically the same. So our brains got all mixed up, and it took 5 years, and there was a full-blown Hashimoto's thyroiditis crisis because we took iodine out of the food supply. We put fluoride in. Our bodies thought that the fluoride was iodine until it realized it wasn't, and then there was the cavalry came, and which is our immune system, and it set off a full-blown crisis. Incidentally, when we took the iodine out of the food supply, there was a massive increase in breast cancers also, because breast tissue responds very nicely to adequate amount of iodine, and it keeps everything nice and calm. And certain medications. This is the workup if you're interested in it. You need to do all of these things, not just the TSH. There's that reverse T3. These are your antibodies here for your immune system. B12, folic acid, and ferritin and iron stores are necessary, as is vitamin D. This is that reverse T3. I sort of alluded to it quickly. Again, this is we use as a proxy for cortisol or stress hormone. These are your antibodies that we owe, TPO and antithyroglobulin. If they have hyperthyroid symptoms, we do something called a TSI, which I always forget what that means, and then the B12, folic acid, and iron. This is the schematic that we use. In the yellow, this is your regular medical doctor. So they'll tell you if the TSH is greater than 10, remember, high numbers are your low, we'll give you Synthroid. If it's 3.5 to 10, if you have those symptoms I mentioned, we'll give you Synthroid. If it's under 3.5, or 4.5 rather, it's 4.5 to 10. If it's under 4.5, you're crazy, go see a psychiatrist. These are all the things that we do. And we look at things like, so a lot of times, quite frequently, about 80% of the times when there's thyroid disease, there are GI issues, food sensitivities, small intestinal bacterial overgrowth, and all sorts of GI disruptions. And so we always look at anybody who comes in with a GI issue, we look at the thyroid. Anybody that comes in with a thyroid issue, we look at the GI symptoms. We'll use levothyroxine, it's just a T4, but we'll look at T3, which is the part that does the work. We'll look at combinations. We like using plant sterolins, which are dampen the autoimmune effect. And we have actually a whole lecture on low-dose naltrexone if you're ever interested in that, in that. White flour, white sugar, dairy, those are the bad guys. Sugar, soy, and corn, they're the bad carbs. Food sensitivities. How are we doing here, Lisa?
Yeah, I think we'll have to wrap it up because we want to get some questions for you. So okay. We'll just have to have you back, Dr. Bill, and have part 2.
All right, so we'll go from next time we'll go from cortisol on.
Yeah, which is a lecture on its own, isn't it? I hope your minds are blown, and I know that you've all got questions, so I'll open up the floor. I'll ask the first question, and then I want you all to unmute yourself if you could, and fire some questions at Dr. Bill. When it comes to thyroid, like it's a very complicated thing, and we're just getting TSHs usually, and people are thinking they're fine because their TSH is in the range, and it's the reverse T3 is never looked at here. You have to pay for it privately, and it costs a couple of $100 by the time you do that. But that's a really critical piece of the puzzle, isn't it? The reverse T3, because and your cortisol and your reverse T3 are very closely correlated, aren't they? So if your cortisol's out and your HPA excess is not doing what it should do,
Yeah, we have generic labs here. I mean, we want to know, how much you're getting cheated. We have a generic lab here that we use. We can get the reverse T3 for $8 if I do the paperwork and send it there, and it goes to Quest, which is one of the major lab companies all over the U.S. I don't know which ones you have there. If I give them the paper that would take their insurance, and the insurance doesn't pay for it, and they go to the same lab, the same person takes the blood, the same machines, I think it's $87 for it rather than $8 on the same machine. So it doesn't
we've got some.
Indeed,
a couple of
for example, $292 on the insurance side. The same vitamin D on the cash side at the same place is $22.95. So
We're getting. Teresa's got a question. She can't unmute herself, but she says, would love to ask about the 3 estrogens. Do you prescribe the individual E1, E2, and E3, or just E2?
Well, there would be no reason to prescribe E1. Estrone that takes you down the 16 hydroxyestrone pathways. Those are the cancer-causing pathways. So we'd be no reason to do that. We do prescribe estradiol, E2 and E3. So estriol is really the pelvic estrogen. And we've been doing that for quite a while. I know there's some practitioners have now decided that's not the right thing to do. And they're all over Instagram and whatnot. But it helps lubricate the pelvic cavity, and it improves vaginal receptivity. Okay, so yes, we'll do a bias. We'll do it in an 80-40, 80-20, 80% estriol, 20% estradiol. Estradiol is about 80 times more potent than estriol, so that's why we do it in that proportion. And we'll do that. Yeah, we do use that.
Okay, excellent, good question. Thanks, Teresa. Who else wants to unmute themselves and fire us a question? I see we've got Melvin on the call and Dr. John Burgess. Thanks for joining. They're part of Dr. Bill's group supporters, and Maria Fogarty. So nice to see you. You guys got any comments? Or I know you probably heard this lecture before, but Dr. Nario, for example, what do you think of? You got anything to add there? You want to unmute yourself? Nobody's unmuting themselves. Okay. Anyone else got any questions? Come on, be brave. Speak up.
Okay. So real quick, this is what you need to ask. Okay. So, or you should be asked. And I have it real quick. And when I have it in my head, I rattle it off real quick. I do this kind of like in a lecture. So for estrogen, hot flashes, night sweats, brain fog, belly fat, memory loss, bone loss. For too much estrogen, cysts, so breast cysts, ovarian cysts, breast cysts, uterine fibroids, gallstones, anxiety, spotting, infertility, joint pain. For progesterone, agitated, irritable, can't sleep, poor libido, headache, short-tempered. For testosterone, anxiety, depression, poor sense of self-worth, poor muscle tone, urinary incontinence, vaginal dryness or erectile dysfunction, libido, poor sexual performance. For too much testosterone, oily skin, oily hair, acne, skin breakouts in the neck and shoulders. The books talk about road rage. I don't see it a whole lot. Every once in a while, you'll hear about it. Acne. For thyroid, dry skin, dry hair, fingernails crack and break, constipation, can't lose weight, cold all the time, tired all day long. The eyebrows thin out at the edges. If you want to be a junior endocrinologist, the inner third of the eyebrow are the sex hormones. So for male testosterone and for female estrogen, the middle third of the eyebrow, that's your growth hormone, and the outer third is your thyroid. So if you look at enough eyebrows, you can actually sort of pick out where their hormonal abnormalities are. Cortisol, the patients are tired when they wake up. They need something to keep them going in the middle of the morning. In the afternoon, they feel like they need a nap, or they do take a nap. They're exhausted by the dinner hour. Later at night, 8, 9, 10 o'clock, they get a second wind. That's when they're most awake, and that's when they do their best thinking. They usually have sugar and salt cravings, difficulty getting to sleep, and then they nod off easily when they sit down. Growth hormone, again, we already mentioned that. Things like memory, concentration, the ability to start projects easily or not, finish projects easily or not, multitasking easily or not, obsessive compulsive tendencies, dark moods, paranoias. Insulin, too much insulin, it's thirst, excessive urination, abdominal pain, and visual disturbance. DHEA is sort of like testosterone. We didn't get to this one. Pregnenolone is the hormone of memory. Low memory, you're going to have low pregnenolone. And for low prolactin, we found this in the head injury patients. These are sort of treatment-resistant anxieties and depressions. So these are folks that they're always looking for the next cure. Nothing ever seems to work. They're on 3 antidepressants, 3 anti-anxiety agents, a couple of other pills to take care of the side effects from the first 6 pills. And they're the ones, they're going to the iridologist, and they're going to the ashram in India, and nothing ever seems to work. And they always have the first, anything new that comes out, they're always the first ones to have it. So that's it. That's your history. This chart here is just a summary. I even have the doses. Functions are in the middle, deficiencies are at the end. You can have these, Lisa.
Yeah,
and then
this is great if we can all get all the slide deck.
It's all in there, but I already sent it to you. And
I've
92
got
references.
I've got a
Yeah,
question from Teresa again. She's got, do you use herbs a lot to help the hormone receptors work better alongside?
We do. Yep. We use a lot of herbs, and that was one of the questions. Remember, I told you, I said you want the herbal remedies. So for our polycystic ovaries, too much testosterone, spearmint tea, 100 milligrams of spearmint every day. Most teas will have spearmint teas will have 70 milligrams. So you need a double bag in 1 cup of water. I usually tell the patients 4 to 5 days a week. It gets a little bit old. You can also use peppermint. It's not quite as strong, but spearmint tea, you will find, will decrease testosterone levels and improve acne and, and all the skin issues that these young ladies have by about 20% within 4 weeks. I mean, it's pretty remarkable. So spearmint tea is really a good one. So black cohosh and chaseberry is another one. And again, we have a whole sort of module just on that.
So we're going to have to get you back for a second session. We've got Ziddy Berger is asking, the use of growth hormone has fallen out of use due to the fear of new cancer cases due to elevated HGF-1. Do you have any comments on that? Someone's got themselves not muted.
Yeah, we've slowed down using it because, again, that's another one of those myths. And bring that one up, but we can show you. We can show we can show you that the patients that have the highest quartile of IGF-1, which is the usable portion of growth hormone, have the lowest incidence of cancer versus those that have the lowest quartile of growth hormone have the highest incidences of cancers. So what you have to remember is whether you have a lot of a certain hormone or a little bit of a certain hormone, it doesn't mean that whatever malady that we're trying to mitigate can't happen. It's all a number of percentages. That's really.
You've also got the peptides now, or at least in America, not so much here. Ipamorelin and the growth hormone secretagogues. So are you a fan of those? And
we've been using them for a long time, and then of course, we when COVID came around, we actually found peptides that had been used in other coronavirus outbreaks. So we started using them, and then of course the FDA decided that they were now illegal. So that's what happened with them. We've been using peptides for a long time. CJC12. So the first one was Semarelin. It was FDA approved here in the U.S. in 1991. It mimics one of the pathways that growth hormone is generated by. So there's two main pathways that growth hormone is generated by. One's called growth hormone releasing hormone, and what that does is it will stimulate the pituitary gland to make growth hormone. The second pathway is growth hormone releasing peptide, and that's in the stomach, and that will stimulate the ghrelin to be produced, which stimulates the pituitary to make growth hormone. So with the Semarelin was the first pathway stimulating the pituitary directly. Then some other ones came out. They were called, I think, GP2, GP6. We don't use those anymore. They had some side effects to them. So now you'll find like CJC1295 with ipamorelin is a growth hormone releasing peptide. Those technically are synthetics, but they work much better. They're much more refined. They're usually just pieces of growth hormone. If you think of growth hormone as a box of Legos. So you get a thing. You have Legos there, and you can make toys out of it. You make a car, windmill, right?
Yep.
So it's 191 amino acids. So 191 pieces. The peptides are pieces of the 191, and the number that you get. So like CJC 1295, it's actually 1 to 29.5. I'll explain what the 0.5 is in a second. So it's the first 29 of the 191. Gotcha. And when you take that solution, the symptoms that you'll sort of alleviate are energy, strength, sense of well-being, and memory. Okay, so that's not too bad. I mean, that's just a piece of growth hormone. The second part, so ipamorelin, there's other ones, tesamorelin, hexamorelin. They all do something a little bit differently. They all work on the ghrelin pathway, so the GI pathway. The problem with the original ones are that you would either get nausea or increase in appetite with them. But the newer ones, the synthetic ones, have sort of dissipated that. In fact, one of them, I think hexamorelin, is actually FDA here approved for what's called lipodystrophy in HIV patients. So you get that big belly. So you can use it for not HIV also. So you'll get combinations. So you get the CJC 1295 with ipamorelin. So it's both pathways. So it's sort of stimulating the pituitary gland the same way we do it. The hypothalamus does it naturally to generate a growth hormone. The advantage is that real growth hormone, so we treat somebody with growth hormone, it shuts everything down. And if you stop, and it's very expensive here, if you stop it abruptly, you're going to get a rebound. The peptides don't shut everything down. What the peptides do is they stimulate your body to make these substances in those pathways. If you stop using it, it's like any other, medication, drug, or I don't know if Botox or whatnot, once it wears off, you're back to where you started from. And they're about 1/10 the price also.
And Barbara, you've got a question there. Do you want to unmute yourself? Go, Barbara.
Hi, Bill. Thanks so much. I'm really enjoying it. You mentioned modules. Is there somewhere we can go and learn more about this? Dive a bit more into it.
We have I wasn't planning on doing this, but we actually have a video course, an introduction to hormone optimization. I can send Lisa the link, and cool. We can get you started on that. Right. We also have one on peptides, introduction to peptides, and they're a little less bombastic than your friend Jay has. Yeah. They're pretty much just the facts. They're not all not all the hype.
You've had too much testosterone.
We do have those. We do have those. I have a lot of sort of individual lectures, also more advanced ones. And if anybody's interested in them, I have like a whole just women's hormones, from start to finish, a deep dive. So we have that. That's about 4 hours. So we have a lot of those things. Yeah.
We'll get those links off you, and people can sign up and do them. And I highly recommend that you will go and subscribe on Dr. Bill's YouTube channel as well, because he's putting up the most amazing lectures all the time. They're very in depth. They're very well referenced. And Dr. Bill, can we all join your group too? Like, are we?
Absolutely.
Yeah. So everybody, I'm already a part of it, which I absolutely love. And I don't get to every lecture because of the time of the day, but it's on in New Zealand. It's 12 o'clock on a Wednesday, or I think it might be 1 o'clock now with the daylight savings. So I will put that link to that as well, Dr. Bill. And this a group of how many are you? 80 odd people, doctors?
Yeah. Yeah, I mean, at any time we'll have anywhere from 30 to 75 to 80. We have a big crowd from the Philippines now, and we have some even in Europe, and it's 3 o'clock in the morning there. So
amazing,
they're kind of hardy souls there. But everything's all on YouTube, and we also on our own website, at aosrd.org. So that's on our own website. So
we'll probably wrap it up there, Dr. Bill.
One quick brag, what I'm showing you here.
You can connect to my hotspot if you see it. It's our usual password.
Somebody's, sorry, I'm going to have to mute someone. Mute Jean. Sorry. Okay, there you go.
This is a magazine in the area where I live here. So the Best of Sierra, to kind of get the vote for the the best hoagie and the best supermarket and whatnot. And so you can see here we won 4 awards here this year, pretty good. So best men's health, best weight loss, best women's, best medical practice. So so we got to be doing something right.
You sure do. That's absolutely gold. Well, I've got to go and get my mum out of bed, and I'm sure, Dr. Bill, you've got to go and rescue someone who's got an IV in their arm. I just want to say to everybody, thank you so much for all showing up. Dr. Bill, you're an absolute legend. I know everyone's going to want more from you and to know more of it from you, and to maybe hopefully join your group, because what I see is this group becoming a part of a bigger international group, and that support network that we can build internationally is really powerful. You know, you've got people in the Philippines, you've got people in the US, and you've got some of the most incredible doctors on your group. And so this is us finding our tribe, people that want to learn the latest and greatest in medicine. And we have different lecturers come on and we do different things, and we don't agree with everything 100% of the time, but it's a really robust place and platform for us to find our tribe and to hang out together and learn from incredible people like Dr. Bill. So I just want to thank you, Dr. Bill, for taking your time, especially, you know, given that you've got in a medical situation at home yourself.
We got to take care of it, so
yeah. So everybody, thank you. Everybody, thanks for coming. And a lot of people are just joining now. Unfortunately, they got the time wrong. So Jean, I'm sorry about that. We will get you the recording. It's been a legend of an hour, so apologies if anybody got the time wrong. That's the problem with, you know, time zones in America and New Zealand and daylight savings. But everybody, thank you so much for being here. Dr. Bill, you're a legend. You're just
thank you. Thank you, Lisa. Thank you, everybody, for being here. I'll talk to you again.
Yeah, very soon. And we'll send this recording out to everybody. Love to you all.
Okay.
Thanks, Dr. Bill. Thank you.
Thank you. Bye-bye.
Bye.